Welcome everyone to this webinar on designing evidence-informed and cost-effective primary health services. We've got about 118 people who have registered for this webinar, so there will be some who will join us shortly, but it obviously shows the popularity of this topic. I'm Joanna Holt. I'm the coordinator of the Partnership Centre for Health System Sustainability, based at the Australian Institute of Health Innovation at Macquarie University. And it is my pleasure to be a moderator for this webinar that will be delivered by Professor John Karnon, Professor of Health Economics at Adelaide University, his colleague Dr. Kenneth Lowe, and Jade Hart, who's the the Chief Executive of Victorian PHN Alliance. So thank you for joining us today. A little context, the Partnership Centre is a large collaboration between system partners and researchers. It's a 5-year grant, and it was designed to investigate and create interventions to improve health system performance sustainability. It has 9 research streams that are all conducted in collaboration with system partners. And Professor John Karnon leads one of those streams under the banner of Better Value for the Health Dollar. The webinar today is based on the research conducted by Ken and John in partnership with Jade and others from Primary Health Networks. So the purpose of the webinar is around designing evidence-informed and cost-effective primary health services. The webinar will run for approximately 45 minutes with time for questions at the end. Can I just acknowledge the Health Services Research Association of Australia and New Zealand, who are kindly hosting this for us. Thank you, Sarah. So without further ade, can I introduce Professor John Karnon, who will give you an outline of the webinar today, followed by Jade Hart, and then John Karnon, and then Ken Lowe, who will complete this webinar. John.
Great. Thanks, Jo. And thanks for agreeing to moderate this session. So Jo's outlined the objective of the session. So we're looking at the use of research evidence in an evidence-informed framework to assess the value, the cost effectiveness of the types of programs that primary health networks are commissioning and procuring. And so we've set the webinar into 3 broad sections. So we're very pleased to be working with Jade, who, as Jo said, is Chief Exec of the Victorian PHN Alliance, and so has direct contact with PHNs. And so she's going to start the webinar by talking about her experiences with PHNs, but also talking and interviewing senior members of PHNs around the challenges of using research evidence. Then I'm going to talk at a broad level around the specific challenges of using the available evidence to estimate cost effectiveness or to undertake economic evaluation in the primary healthcare setting. And then we'll hand over to Kenneth, who's going to provide the bulk of the webinar, which is presenting a case study that we've been working around developing a framework for using research and, as we'll define it, non-research evidence to assess the value of alternative options for program delivery. And then we'll finish with a summary, and Jo will moderate a Q&A session. So without further ado, I'll pass on to Jade, who's going to take the first session.
So hi everyone. So I'll be presenting an overview of primary health network commissioning and procurement, and report on PHN perspectives of the considerations for research evidence compilation, dissemination and use. So as background, my name's Jade Hart, and I'm the manager of the Victorian and Tasmanian PHN Alliance, which is the collective platform for Victorian and Tasmanian PHNs. So the Alliance seeks to optimise the collective capabilities of PHNs as a sector and proactively align our jurisdictional efforts and advance primary care reform. And so personally, my research interests are linked to evidence-informed system-level decision-making. So today's symposium is really, I guess, of interest from a practitioner and a researcher perspective. So next slide. Okay, so the PHN program is an Australian government initiative in support of primary care reform. 31 PHNs were established in 2015 as organisations that are tasked to deliver on two core objectives. That is to enhance the efficiency and effectiveness of medical services for patients, particularly those at risk, and to improve the coordination of care. PHN efforts are framed in relation to geographical catchments. Hence, PHNs are highly heterogeneous in relation to the populations and the places that are served. As a result, the issues, priorities and opportunities that are afforded to each PHN are highly contextualised and responsive to communities served. There is recognition that what works in inner city Melbourne will differ to what may work in Alice Springs and indeed inner city Brisbane. Achieving granularity and specificity of local insight remains our key objective. PHNs are meso-level or mid-level entities nested between the three tiers of government and the breadth of individual providers, organisations and the community. Within this space, PHNs achieve influence and support health improvement through, firstly, PHN primary care commissioning, which covers a whole of organisational approach to the examination of population needs, service capability, planning responses and the procurement of new services to meet those needs. Secondly, PHN serve as quality improvement partners working alongside general practice and other organisations to work towards best care. This is done through the development of localised care and referral pathways, referred to as health pathways, engaging with providers and organisations to support workforce development, and supporting digital health as an enabler for coordinated and integrated service responses. Commissioners have a role in deciding which services or healthcare interventions should be provided and which outcomes need to be secured, who should provide them and how they should be paid for. PHN commissioning is framed in relation to three key stages: planning, procurement and monitoring, alongside which a range of processes are undertaken and a suite of core deliverables are prepared. Commissioning covers technical, transactional, but importantly relational elements. So this is where PHNs leverage implementation science principles through consultation and co-design strategies with communities and providers, using quantitative data, including service and population health data, and supporting ongoing review, improvement and accountability as part of overall system development. PHNs are guided by a suite of national priorities and the Program Performance and Quality Framework, which seeks to facilitate improvement, performance outcomes tracking and measurement against those two core objectives. It is within this broader commissioning framework that procurement occurs. The process is structured in terms of planning, management and closeout. A range of inputs, including insights, guidance, policies and procedures, inform approach to specifications, evaluation, selection and contracting. So this slide gives you two vignettes of the sort of interventions for which PHNs might procure services. These examples highlight the way in which innovative responses must be procured to examine issues of need, including those issues that might meet the tenets of being considered a wicked issue, prevention, early identification and treatment paradigms, service and contextual features, so we think about workforce, location and culturally appropriate responses, and a biopsychosocial model for health for which outcomes must be assessed. These vignettes also demonstrate that PHNs do not procure simple interventions that have few mechanisms. Rather, service responses are inevitably complex and multifaceted. So there are a number of considerations for how research evidence informed practice is undertaken by PHNs. So to inform today's presentation, consultation was undertaken with representatives from 8 of the 31 PHNs across 3 Australian states, so just over a quarter of PHNs. Participants were a mix of management, executive and CEO, and all had been in their role for at least 1 year, so across a whole annual commissioning cycle. So from this, a number of key themes emerged in relation to people, procurement processes and systems, and the underlying primary care evidence base. So people refers to the capability of PHN staff, but equally service providers and partners to engage with research evidence as it pertains to procurement. From an internal people or staff perspective, PHN representatives described procurement and commissioning competencies as a relatively emerging skill set in the Australian context. It effectively blends content expertise, including sector knowledge and capacity to evaluate sector-specific evidence, with generalist skills in planning, engagement, procurement, so those technical capabilities and strategy development skills, as well as leadership and management. From an external people perspective, PHN representatives highlighted the influence of the capacity and expertise of those within research generating or synthesising functions to work with PHNs collaboratively and strategically and retain independence in their approach. And PHN representatives also highlighted the importance of service provider capacity to have access to and comprehensive understanding of the evidence base, such that providers can draw from this to inform tender response development and demonstrate ability to implement evidence-informed strategies and practices. From an internal and external people perspective, there's value in collective development strategies. A number of PHNs reported efforts underway to foster this, such as through internal staff development against the commissioning competencies, working with the sector to build capability and procurement tender response skills development, as well as individual-based partnerships. So from a procurement process perspective, these were seen as being acknowledged by a range of factors. A common theme that emerged were that processes have been established over the last few years, but are in no ways considered static. PHNs are continually looking to refine and improve processes through structured approaches to feedback. PHNs are individually building this knowledge base and learning and are working collectively through communities of practice or peer network structures to facilitate knowledge transfer. The insights developed a sharpening understanding of the breadth of service system responses available. A rigid approach to procurement will have its limits, and PHNs are building a deeper understanding of whether to procure, what to procure, what level of specificity is required at design, when to co-design with stakeholders in the community, and when to co-commission jointly or jointly procure as a group of PHNs or collectively with other commissioners such as state and territory governments for best outcomes. PHN representative also acknowledged that there are corporate governance obligations and other departmental guidance that exist, and that being evidence informed is one of multiple measures of process effectiveness. So a systems or a cross-organisational approach to fostering research evidence-informed procurement process was seen as being required at various levels. The way in which PHNs collaborate and build ties with all partners to support the generation, compilation and use of research evidence, the way in which professional bodies, peaks and service providers are placed to support sector-led evidence use, and PHN collaboration with academia and specialist advisory-oriented structures. PHNs reported the benefits of formal academic partnerships, advisory structures to support collaborative efforts. So, for example, the National Centre for Immunisation Research and Surveillance and MPS Medicine-wise work with PHNs to support immunisation efforts, really guided by a user-oriented approach. And finally, the adequate time and secure resourcing to support evaluation and evidence generation to inform future commissioning cycles. So finally, the research evidence base itself was covered. PHNs reported that the application of research evidence was linked to the capacity to have research that offers insight into the questions, issues, needs identified across the commissioning cycle. So this means that research evidence must often be assessed against expectations for quality with due consideration of context, so thinking about workforce, funding, practice and policy, and within the limits of availability. So PHNs can examine issues for which a mainstream approach may have had limited success in the past, or where innovative solutions are required from the perspective of community and providers. In some instances, the research evidence may not exist. So commissioners need to balance uncertain evidence, a lack of evidence, and the risk that this affords. PHN's also highlighted the importance of connections with research generating and synthesising structures, including universities. And some of these partnerships are established and formalised through a memorandum of understanding between parties, while others are emerging and informal. At a more strategic level, there's the potential to collectively contribute to primary care research planning and the establishment of a more coordinated approach to flagging the research evidence needs and priorities of commissioners. So finally, PHNs are in a consolidating and maturing phase. Learning and refinement of the approach has been the focus for PHNs individually and collectively. The role of research evidence is acknowledged, providing the basis for the design and implementation of service system responses that will meet the needs of historically underserved areas. So in summary, the consultation process identified 4 key points. There was consensus support for frameworks to facilitate the optimisation of research evidence-informed procurement. That evidence use itself is linked to expectations for legitimacy, accountability, and transparency. However, the positivist view that the only authentic knowledge is scientific knowledge can contrast with existing policy and care paradigms. Legitimacy for PHNs involves engagement with the sector and the community on needs and options going forward. Procurement processes can be rigid and focus on individual elements of care, so thinking about appointments, etc. Yet the move towards funding for outcome, impact and value is a relevant development that shifts the focus from throughput. Research evidence must play a role in how this is understood within a biopsychosocial measure of health. Investment and commissioning in the primary care sector, finally, is solely not undertaken by PHNs. Therefore, this is a shared question borne by all primary care commissioners, including the Commonwealth, state and territory governments and compensable care organisations such as our partners, the TAC and WorkSafe in Victoria. PHNs serve as policy implementation labs to explore what works, but also what works where and under what circumstances. And we look forward to continued partnership around how we can optimise evidence individually and its use, and scale and diffuse innovation collectively for improved patient outcomes. Thanks.
Thanks, Jade. That's great. So that provides a really solid background to what PHNs are doing and the challenges that they're trying to grapple with in terms of using research evidence. So I'm going to talk now focusing on the challenges of undertaking economic evaluation or assessing cost effectiveness in the primary health setting, or specifically around the types of programs that PHNs are procuring. So just to start with a very basic definition, just so we're all on the same page of what economic evaluation is aiming to do, and that's essentially to compare the costs and the outcomes, or the costs and the benefits of alternative courses of action for meeting a particular need. And so the most common area in which economic evaluation is used in a decision-making setting in Australia and most other countries is around decisions to fund or publicly subsidise new pharmaceuticals. And so in that situation, we've got usually a new drug, and we're assessing the costs and the outcomes of the new drug compared to the costs and outcomes of, say, the current drug that's used to treat a particular condition. And the decision we're trying to address is whether the additional benefits of a new drug justify any additional costs. So that's a kind of common question or funding decision that economic evaluation is currently used to address. So we might then think about what types of questions might economic evaluation be used to address in the primary health setting, specifically relating to primary health networks. Well, as an example, we might be looking at alternative design options for a drug and alcohol program. And the question there that we might hope economic evaluation can help us with is which design option, which program for addressing drug and alcohol issues generates the most benefits given the funds available or the funds that have been allocated to that particular priority area within a primary health network's jurisdiction. So similar types of questions, just a slightly different slant. When we're looking at new drugs, we've generally got two courses of action, the current drug versus the new drug. In a primary health network perspective, we may have many more than two potential courses of action, and that's certainly what we'll be hypothesizing. So if we start by looking at how economic evaluation works when we've got what I've termed relatively simple economic evaluation context, we've got simple interventions, new drugs. Clearly there are issues around adherence and some of those other issues that can affect the effectiveness of drugs in different contexts, but relatively simple intervention. We've got relatively simple evidence in that for most new drugs, we have evidence from high quality randomized controlled trials that provide non-biased estimates of the effects of these new drugs compared to current drugs. And we've got accepted methods for estimating costs and outcomes using these data, which are generally represented in the form of a cost per quality adjusted life year, QALY gained. And the decision that decision makers are faced with is this type of decision is, should we pay $40,000 to gain an additional QALY from funding a new drug for a particular condition compared to an old drug? So I'm certainly not suggesting these are simple questions and decisions, but as we'll see, relative to the types of interventions and data and decisions that primary health networks are making, they're relatively straightforward. So the first thing to note is that PHNs generally commission complex interventions, and so Jade has already alluded to this fact, and these four characteristics have been defined by the Medical Research Council as characteristics of complex interventions, and we can see how they relate to the types of programs that PHNs are commissioning. So a program has got multiple interacting components. So a program for drug and alcohol, for example, may be looking to increase access to services, to better integrate services, as well as improving the quality of the services provided. Multiple stakeholders or organizations are targeted by the intervention. So clearly we've got different health professionals, but we also may want to link in with social services, so welfare, employment, and family services, so a whole range of stakeholders and organizations. The intervention requires behaviors to be made by those both delivering and receiving the intervention for the intervention to be effective. So, for example, need adherence or compliance and use of stepped care models requires those behaviors. And clearly, there's heterogeneity in terms of the target population, so flexibility or tailoring is required depending on individual need and stage of change, for example. So I think in most cases we can certainly describe how the programs commissioned by PHNs are complex. And along with complex interventions, we have complicated evidence. Even if we're just looking at the research evidence around these types of interventions, it's complicated. So we have different studies will evaluate heterogeneous or different interventions, all with the same general objective, but often not much commonality across the types of interventions that are evaluated. They're evaluated in different locations using different study designs with varying quality, and it includes both qualitative and quantitative evidence that is potentially relevant to inform the value of alternative program designs. And then on top of that, we've got what we've defined as non-research evidence, which is generally evidence related to the local context. So what are the characteristics of the local population? What are the current outcomes for the local population? What services are currently being provided? What's the capacity to provide new services? Are all program options feasible in the local context? And then we need to take account of stakeholder preferences, and that includes both health professionals, healthcare organizations, as well as obviously consumers and the target population. So there's a lot of evidence that, in an ideal world, would be used to inform the design and the assessment of the value of alternative program options. We've also got different stages at which PHNs are looking at the value of program options. So we've defined two broad stages. We've got the pre-implementation stage, which is where PHNs are designing programs prior to implementation. And at this stage, we would suggest that in terms of the research evidence, you're really reliant on what's been published. And as Kenneth will talk about and illustrate, there may be some limits on the feasibility of estimating or generating accurate estimates of the expected outcomes of alternative program options. And so we may be looking at comparing costs with some estimate of the relative importance of program features. So Kenneth will talk about that. And then in the post-implementation phase, where hopefully there should be some evaluation data post-implementation of a particular program design, how do you review the effectiveness and cost effectiveness of the program that you've implemented, and potentially use local and published research evidence to improve or refine your implemented program. So the types of questions that we've been thinking about how we might, as academics, look at to work with PHNs around this issue of looking at the value of program options is, how do you use the research evidence? Which research evidence do you include? How do you synthesize that research evidence, qualitative and quantitative? And then if you've got evaluation data, how do you synthesize it with that? And so that's the combining of the research and non-research evidence, what local data, how to represent costs and benefits in the local context, and then how to share that information with stakeholders to be able to incorporate their views. So our aim, what we're really hoping to be able to do, is to work with PHNs to investigate and support this process of using research and non-research evidence to estimate costs and benefits. And to start that process, we've kind of been thinking about a potential framework, and we've undertaken a case study to illustrate how the framework might be used to look at the research evidence. And we've used the case study of program options to reduce hospital transfers from aged care facilities. And so Kenneth is now going to talk through that case study.
So thanks, John. So I'll run through the steps of the framework, what it entails, and we'll use also a case study on residential aged care to illustrate how it works. So we call the framework in-depth. So what it means is actually evidence-informed co-creation framework for the design, evaluation, and procurement of health services. So this slide shows the overall steps involved. And basically, I'll start with the first step, which is actually to define the research question with commissioners. So this is a very important step where we sit down with the health commissioning agencies to understand what are the population profile, intervention, the context, and outcomes. And because it's important, because at the end of the day, we want to come up with findings that are useful, that are relevant to the commission. So after this has been defined, then that's where we will go look for the evidence from all the databases. And for this type of evidence, for quantitative evidence, we actually try to do a meta-analysis if suitable, because we're talking about complex health interventions where there are different components involved. So heterogeneity is quite high, likely to be high. So we have to look at it to see whether it's suitable. And for the qualitative studies, that's where we can actually extract some of the barriers and facilitators. So some of these studies will be interviews with various actors in the systems to understand what works, what are the problems, what are the solutions. So based on this data, we can actually extract all this information. And then from this information, we can group similar teams together. And then from these teams, then we convert this information into program features. And these features that we extract from these quantitative trials can also be compared back to the studies that were included under the meta-analysis, the quantitative studies. And the aim is really to understand why certain trial works and why certain trials don't work. And of course, if there's any learning points that we can use to incorporate back into these features as well. So the case study, I'll illustrate how this principle works. After this, then we will try to synthesize the features that we have found together with information from existing procurement specifications. And if there's any trial from all these quantitative trials that is positive and we understand why it works, there is also a source of information that we can compare across. So at this stage, there's a lot of co-creation with stakeholders where we try to understand their point of view, the local context, what has been specified in the existing procurement specifications. And the end point of all these program features is really to come up with information that can be directly used in the procurement of services. So these features is something that we hope can be straight away be used in the procurement specifications. Thereafter, then we'll look at search for further information on outcomes and cost data for each of these features. So we'll look through data from existing PHN information, what evaluation data they have, and of course, published and grade literature. So this step here can be an iterative process because as we find certain information on outcomes, cost data, or methods, these can help to refine the features again. So there could be a bit of a feedback loop along here. And then after we have found the additional data, then we can do a Delphi survey. And that's where we actually organize a survey with various stakeholders. They can be consumers, clinicians, healthcare providers, or other government bodies. And the aim of this survey is really to prioritize all these features to see which are the most valued and which are the less valued features. And that will then help in decision making. Yeah. So let me go to the case study. We actually use the residential aged care facility as a case study because it's one of the key priorities that primary health networks have identified. So the research question here is, how do we improve care and reduce hospital transfers from residential aged care facilities? So based on the question, we actually searched the various databases, PubMed, Embase, and CNOW. So we came up with about 900 records. And after screening based on the inclusion criteria that we see here, we actually left with 12 studies. So 4 are quantitative studies and 8 are qualitative studies. So for the quantitative studies, we actually do a meta-analysis. Meta-analysis is actually a quantitative analysis method where from outcomes, the results of individual trials, we try to calculate a pooled effect. So here we see that these are the 4 trials here. 2 are from New Zealand, 2 are from Australia. And these are the individual outcomes. And the pooled outcome, the average effect, pooled effect is basically this represented by this symbol. So under the meta-analysis, there was an inconclusive finding, as you can see from this diamond shape, that it actually crosses between intervention and control. So we are not able to have a definitive outcome, understanding from meta-analysis. And we also noticed that heterogeneity represented by this indicator here is very high. And it's high because each of these trials, even though they are measuring the same outcome here, which is hospital admissions, number of hospital admissions, but the components within their models of care are all different. So that's why the heterogeneity is high, and which is a limiting factor for this sort of analysis. And additionally, the studies are also of different designs. So these 2 are randomized, cluster randomized trials, where these 2 are pre-post studies. So in view of this limitation, that's where we turn to qualitative analysis. So here we try to understand the barriers and facilitators, and then from there we extract the program features, which you see on the right-hand side. So each of these, the individual 8 studies are actually listed here. You can see there are 8 studies across the top row. So the first 6 are primary studies, and the last 2 are actually systematic reviews. The first 6 studies are all Australian-based studies. So for one particular topic theme, we group them, all the findings together. So in this case, we are looking at the area of advanced care directives. So we see that there are about 6 studies that have information related to this. 2, there isn't any. So we try to do an aggregation, a summary of all these features, information, to come out with something that captures the essence of all this. And at the same time, we also try to capture very specific details. For example, here, someone has mentioned about having explicit notes and a commitment to stay the course of care. So these we also incorporate into this feature, because at the end of the day, this will go into procurement specification. So we have to be detailed and specific. If there's any useful information, we incorporate as much as possible. So next, we actually then, based on these identified features, we then compare it back to the quantitative studies, the 4 quantitative trials. So then we compare across each feature, we extract the information from each of these studies that relate to this particular feature. So in this example here, they're talking about access to available clinical expertise. And for each of these trials, we then extract the relevant information. And if you look horizontally across, we can also see the different intensity of activities. So we can see for the trial by FAN, they actually have a wider range of activities, and they also have a dedicated nurse to manage this program. Whereas in the trial here, we see that they actually talk about the time commitment was only 20% across all facilities. So looking horizontally, we can actually notice that there's a variation in the number, the intensity of activities. So that tells us some information about why certain trials work and why certain trials don't work. And if we look at it vertically as well, when we match back the features of these trials back to what we have identified, we can see that the FAN trial also has a larger number of features that corresponds to what we have found. So in a way, this also tells us, that this particular trial has a positive outcome. Also, because they also have there are more findings that corroborates with what we have found also. So in a way, for this particular case study, we see that the FAN trial is something that we can use. It could be used in the synthesis of evidence later on when we compare back to the procurement specifications. And this is what I mean here. So here we have our program features that we extracted from our qualitative studies. Here we compare it to the existing specifications that existing PHN have. If it's a new program, then it could be expert opinions that could be here instead of existing specifications. And here we list down what the trial says for this particular area here. So here we're talking about advanced care directives. So for this trial, they don't have there isn't any information. But do notice that we try to be as specific as possible. So existing program, for example, there's this mention of a specific tool. They call it 7-step pathway. So in the synthesized feature, we try to incorporate all these details to make it as complete as possible. Because at the end of the day, we want to use it for procurement specification. So any useful bits of information, is incorporated here. So this is a summary of what we have found for the case study. There are altogether 19 features. I think we'll talk about the advanced care directives. There are also certain features that talk about training and education, about upskilling. And there are also certain features that talk about having a certain medical equipment, medical medicines on site to facilitate acute care. And there's also some features that talk about having standardized procedures for transfer to emergency departments, EDs. And so there are some features that talk about the need to have after-hours management plan at the facilities themselves. Also talking about maybe having computerized records at the facilities to facilitate easy access to residence history by the GPs, and also to facilitate transfer to ED. And there's also some that talks about having allowing care staff, assistant in nursing, to be able to administer medicine besides just the registered nurses. So for each of these features, we then go on to search for further information in terms of outcome and cost. So here, for the example of the Advanced Care Directive, we actually have found another study that actually has done an economic analysis of advanced care planning. So in their economic model, they actually considered 4 consultations for a person, that's reaching 65 and above. And based on this, their intervention model, they actually found that it is cost effective. And they also identified certain sensitivity factors, for example, the uptake rate, the Advanced Care Directive rate of uptake, compliance with it, and of course, end-of-life choices, whether they are dying at home, in facility, or hospitals. So based on certain parameters here, they found that their case study was effective. So these are information that, we have to sit down with the stakeholders to discuss, because, do we adopt this model of care, this model of intervention? If yes, then that will go back into the feature descriptor, because then this information will be added in. And then we also can discuss about, do we want to add in certain outcome parameters as well? Do we want to specify that there should be at least 50% uptake? So these are things that we have to co-create with the stakeholders in order to really enhance what we have identified. So in terms of the costings, we also done costing based on the economic model of the previous study. So they are basically we costed for 4 meetings based on MBS schedule items. So this cost is actually on a per resident basis, and it's also important to consider the different perspective. So in this case, this is from the perspective of the primary health sector, the cost of the GP itself. And so there's also the cost at the facility itself, because there's also a need for a nurse to do the coordination. So that is the cost perspective of the facility. Another aspect we also have to consider is about startup costs and running costs. So in this example is running costs. So if there's any startup costs, for example, if they need to set up a room, so all these have to be added in. And all this we also have to discuss with stakeholders as well on how to manage all these cost perspectives, cost data. And after all this information has been found, for each feature as much as possible, we then go through a Delphi process. The Delphi is actually a survey method where the group results of one round can actually help to inform subsequent rounds. And in our Delphi, there are actually 3 rounds. The first round, we actually rank some of these, all these features based on the level of benefits to patients, to residents. I think this is important because ultimately, whatever we do, there should be benefits to the patients. And after this, in the second round, we actually rank this feature based on the level of difficulty of implementation, how difficult it is to deliver these services. And at the third round, that's where the group results from the prior 2 rounds will help to inform, to guide the participants on the final ranking. So taking into account the group result, the level of benefits to patients and implementation difficulty, they will then do a final ranking of all the various features. Just to share some observations that we have uncovered from this case study, there were some features we realized that were not actually procurement specific, but they were actually quite policy related. For example, accreditation to allow certain facilities to provide acute care, especially if they are registered as low care. And also if it's possible to allow assistant care staff, non-nursing trained staff to provide, to dispense medicine. I mean, there are different medicine schedules that have different levels of control. So these things, these features may need to be discussed with stakeholders on how to manage them. Do we need to surface it higher for policy decisions? And so we also realized that some features are actually acute care related, not just primary care related. So because there's one study that deals with hospital outreach program, so there were some features that dealt with transfer between facility and ED, and then the discharge protocol from ED back to facilities. We also realized that some features are also more difficult to cost, for example, medical equipment on site. So for this, we actually need to sit down with providers to understand what type of equipment they usually use to provide on site, what type of medicines they usually store on site. At the same time, it's also about adequate staffing level to handle unexpected events. So this, we also need to speak with the providers to understand how often this occur, when it occurred, is it on the weekends, is it daytime or nighttime, because all this will affect the cost. So the discussion with stakeholders is important here. We also realized that all these studies were talking about physical and medical care. They did not touch on emotional care. So again, we had to discuss with stakeholders, should we apply the framework again, specifically to look at emotional care to uncover the evidence there. So, that's where the co-creation comes in to give us the guidance on how to actually proceed in this respect. And there's also this, how do we go about doing the Delphi as well? As I mentioned, we have actually a positive trial from the quantitative studies. They were introducing a hospital-based outreach program. And there are actually 12 program features which maps back to this program they call it HIN. And there are actually 7 features that are standalone that are not related to this HIN program. So the Delphi process is, do we then rank all the 19 features that we have found, or do we just rank the 7 that we have identified that is not replicated in the HIN program? So, and if we do rank all the 19 features, is it possible? Does it still work? Because we are talking about a system of components. So we split it up. We're not sure whether the end result will still be the same. So all this basically is where the co-creation comes in. That's where we need to sit down with stakeholders to also discuss, how do we go about doing this Delphi as well. So just as a summary, so in that it's actually a very structured approach whereby we try to combine evidence from empirical studies, from qualitative studies, and then we try to then merge it with locally relevant contextual information. I guess this is very important in order to have a better translation from evidence into practice. And also in that also offers a very clear touch points with stakeholders where they can come in to contribute in a very meaningful way. For example, to defining the research question, through synthesizing, identifying the program features, and participating in the Delphi. And of course, we would like the framework to be very more useful, whereby we actually generate useful outputs that can be directly be used as procurement specifications, so that whatever we have done can be used downstream as well. And there are certain limitations to this framework. So, of course, we need to have a sufficient base of evidence in order to have sufficient information, evidence in order to have enough features that we can identify that is meaningful. And stakeholder participation in co-creation, in joint discussion is very important. As we can see, there are a number of questions, a number of things that we uncovered that we need to discuss on how do we proceed with those. And lastly, in terms of the Delphi, because in terms, for example, there will be some cost benefits that will cost more for party A, but cost less for party B. So when we do a Delphi, we have to be aware that we actually have a balanced representation from various parties because of these different cost perspectives. So with a balanced participants, then we have more reliable results. Otherwise, it could be skewed to certain organizations. Yeah. And with this, that's all I have to say about the framework. I'll hand it back to John. Yeah.
Thanks, Kenneth. So I've just got, so hopefully that's nicely illustrated where we're at in terms of our thinking and research around the options and approaches that could be used to inform the value of alternative program options, and we're really keen to apply this framework in practice in collaboration with PHNs. So to inform any questions that we may want to discuss, I've just put this summary slide together. So the first bullet point relates to what Jade was talking about, the fact that there's all these other inputs that need to be considered in the commissioning and procurement process, and that I think the take home for me was, or the kind of the one line take home was that the positivist view of just using the research evidence is not applicable essentially in this setting. I think Kenneth has illustrated nicely that it's really difficult to disaggregate the effects or the potential effects of multi-component services. And you may have noticed that we use the term evidence-informed rather than evidence-based, which is perhaps a more common term. It represents or reflects this need to interpret complicated evidence in a local context, and this question of how to use both the research and non-research evidence to estimate costs and benefits or represent costs and benefits of alternative options is difficult. And so I guess the final point I wanted to just put up for discussion really was whether there's the scope for centralizing some components of this process. So is the scope for maybe the centralized analysis of the research evidence, which then feeds into a local process for synthesizing and interpreting the research and non-research evidence in the local context. So kind of just putting that up there as a potential way forward to reduce duplication and make the process more efficient. So I'll stop there, Joe. So if you wanted to tell us if there's any questions. Just have to, there you go.
Thank you very much indeed, Jade, Ken and John. That was a really interesting presentation. So we've now got time, about 5 minutes or so for some questions, and then probably, John, you may want to say something at the end regarding getting some partnerships going with some of you who are listening today to trial this research framework. Okay, so to start with, we did have a question about whether Ken's meta-analysis has yet been published. I understand that's coming out soon, Ken?
As in this framework?
Meta-analysis.
The meta-analysis.
As in for this particular case study,
the one that you put.
Actually, we are drafting the paper about the framework, but the case study for this meta that we have done is actually, it could be published in the second paper. Yeah.
Well, the framework itself is a manuscript that's under review with BMJ open.
Thank you. Right, question to Ken. The framework only appears to include features that are already examined in the literature. How would you bring in novel features?
That's where I guess the stakeholder inputs will come in rather useful, because I mean, from evidence, there's a certain boundary. I mean, it's what has been interviewed, what has been discovered is there. But I guess if there's any existing novel feature, hopefully it's covered by the evidence. And but if it's coming from the provider's point of view, that's where the stakeholder engagement can come in nicely as well. Because when we sit down with stakeholders and they have a different take because of certain local conditions, like Jay has mentioned, maybe resource capacity, that's where we can actually modify, adapt the evidence. Yeah. But ideally, it will depend on how broad the search is, and ideally, based on these search terms, we will then capture as much evidence as possible.
But I think if stakeholders were to come up with new features, we could certainly look at the costs of those new features, but then obviously there wouldn't be any research evidence, so it would be down to the interpretation of the stakeholders about the relative importance or value of those of a new feature relative to features for which there is evidence.
Yeah, and that's where the co-creation all comes in. Yeah, to define, how many features, additional features. Yeah.
Okay, thank you. A question to Jade. It was a question about, can you elaborate on what policy implementation labs constitute?
Yep. So primary health networks across Australia are the framework for national reform implementation. So whether that's through national strategy, national frameworks, recommendations from key commissions, they basically provide the clear guidance for which PHNs locally implement. So the notion of policy implementation labs basically is a term that describes a framework where there is national guidance, recommendations, or a sense of what should be implemented locally, through which PHNs then go through a local process of working with stakeholders, drawing on the data to understand need, and working with services to think about how that could be implemented. So the distinction between policy as outlining the what and PHNs exploring the how in terms of what that might mean for individual catchments.
Thank you, Jade. I think we've got time for one last question from Harriet in Melbourne. Hello, Harriet. How do you weigh up successful factors from randomised controlled trials with successful factors from non-randomised trials in your framework? This is to Ken and John.
So it's really asking about how do we weight the evidence,
yes,
in terms of randomised versus non-randomised. Well, I mean, so that's going to be a key part of how we present the evidence to the stakeholders, because ultimately it's the stakeholders who are interpreting the evidence. So that's our challenge, is to describe the strengths and the weaknesses of the evidence. And you can have good randomized controlled trials and poor randomized controlled trials, and likewise with observational studies. That's part of I guess that's incorporated in the framework through how we present that and inform the stakeholders about the strengths and weaknesses, so that they can incorporate that in their their views.
There's also the evidence quality assessment that we do for all these trials. It's not shown in the slides, but we actually did assess the quality based on certain checklists for different types of studies, randomized studies, non-randomized studies. So if there's any studies that have very low score in terms of evidence quality, then that will be an obvious way to question whether we include them in the analysis or not. Yeah. But having said that, we also have to bear in mind our original thinking is that these are complex interventions. So in terms of meta-analysis, it may not be that straightforward. So actually our framework, we are trying to combine both quantitative and qualitative evidence. But a lot of it, as we can see from the case study, for this particular case study, is driven by information from qualitative studies. Yeah, because quantitative-wise, we were unable to reach a very specific conclusion. Of course, in terms of the features themselves, when we search for outcomes, if they are very specific features, for example, we talk about advanced care directives, if there are a couple of studies that do an economic analysis on this, and they measure the same thing, it could be possible to do some meta-analysis at this smaller scope, rather than at a broader, complex intervention level.
Yeah.
Okay,
yeah,
thank you.
I was just going to say, I think what we're saying is that, as I kind of mentioned earlier, is that it may not be possible to generate specific estimates of the costs and benefits of each program feature. So it's really using the evidence. That's our goal, but we may not be able to achieve that for all of the program features. So
Okay, well, thank you very much. Before we finish, and I thank the speakers, John and Ken, you might like to just tell the participants what you're planning to do next with this framework.
Yeah, so as I've kind of mentioned at various points through the webinar, we're really keen to work with PHNs to apply and test the feasibility and value of this framework that we've developed and applied. I guess we've only applied as a desk-based application to date, so we really would like to apply it in practice. And as Joe has said, this has all been done as part of this Partnership Centre for Health System Sustainability. So there are research resources available to support that process of collaboration. And to emphasise that, really are stressing the co-creation aspect of that. So we're not wanting to come in and say, this is what you should be doing, this is what you should be looking at. We want to work with you to identify your priorities and what will be most useful from your perspective. And also just to note that there is a broader group of us involved in this work. So Jill Harvey here at the University of Adelaide, Suzanne Robinson over in WA, Josh Brines at Griffith. Is there anyone else? I think that's it. And myself, Jade and Kenneth. Jade and Kenneth are all working on this together. So yeah, just that's our next steps. Hopefully our next steps.
Okay, thank you very much. So that's a call to you all to get in contact and suggest some areas where you would like to try and use or test this framework so that we can actually make it really useful to all of you who are working hard out there to get the best services to your populations. So before I thank everyone, can I just tell you that this webinar has been recorded and it will be available courtesy of Sarah Green at the Health Services Research Association of Australia and New Zealand website. And there's the link, and also on our Partnership Centre Health System Sustainability website. It may take a few days for them to get up there because they will need a little editing. We also, John and Ken and Jade and the Partnership Centre are hoping to get you a easily digestible fact sheet out about this framework, and we'll be sharing that again on our website in the next few weeks. So thank you, Jade. Thank you, Ken. Thank you, John. Thank you to all of you who participated today, and Sarah for hosting. Farewell.
Thanks, Joe.
Thank you.
Bye.
Bye.